withdrawal symptoms. Now the symptoms of withdrawal usually last anywhere from 24 to 72 hours. Cravings are not necessarily they can be a part of the withdrawal symptom, but people's desire for the drug beyond that is usually not due to the withdrawal from nicotine. So some of the symptoms are listed there for you. If you've ever been around somebody who's trying to quit smoking, you would readily recognize most of these. So anxiety, depression, insomnia, irritability, usually that's a fairly common one. Drowsiness or headache, so you can see seen as stimulation or depression. Changes in heart rate, increase in appetite, and then weight gain over a longer period of time. Okay. Been around smokers before that have tried to quit? It's very difficult. Very difficult. So let's look at the behavior. So the psychological dependence it addresses more the cognitive and the emotional aspects of addictive behaviors or their withdrawal process. So some of those symptoms that are more related to that go to cravings, anxiety, their ability to concentrate will change. They will notice a difference. Mood swings, appetite swings. Smoking does a couple of things. It depresses their appetite. It also changes the way their sense of smell and their sense of taste. So they often will tell you after they quit is that food tastes different. It tastes better usually, and they can smell the food. So that also goes into the increased food intake and the weight gain that's associated with it. Denial could go with this, denial that it's a problem, their uncertainty about being able to quit if they had to, obsessing over getting the drug. So all of those go into psychological addiction. The biggest, so dopamine effects are tremendous, and the effects that people get from that are not to be underestimated. But one of the other things that happens with smokers is that they begin to associate it with behaviors. So what kind of behaviors do we couple with smoking? Drinking. So you go to a bar, you can't even see because of all the smoke. What else?
Driving.
Driving. So more anxiety situations. What else? Morning coffee. Yes. So they link that coffee and the cigarette. Anything else? You hit some of the big ones. Yes. Did you have one? You just waving at me.
Children.
So in the smoking cessation clinic we ran, we talked a lot about the behaviors because the body gets very used to cues. How many of you can get here and think, I don't even remember driving here? Okay, so the more you do things, the more the body goes, okay, this is the way they do it, and it puts it down into more subconscious. Do you have to think very hard about getting here? Okay. I would challenge you this week, go home a different route, see how much more you pay attention. You are really dependent, our brains are very dependent on cues. So one of the things we do in smoking cessation is we try to uncouple those cues. So simple things we'll have people do is, if you always sit at the same place at the table, if you always use the same cup, then sit at a different place and use a different cup. It just tells the brain, it's different, this is different. The other thing is, what do you do after you drink your coffee in the morning? If you light up then, we sometimes tell them, get up and go do something else. Let the brain know that this is now different. In the car is really hard. So what we usually would have people do is, once they set a quit date and they get close to it, is go clean your car out. And also get it detailed, because the car will reek of smoke that you will now be able to smell. So things like park it in a different place, driving to work in a different way. Think about what sets off your need for a cigarette and having them have alternatives. So a lot of smoking cessation is actually problem solving. What are you going to do when you get to a situation where usually you would reach for a cigarette? So we do a lot of talking about that, and we do a lot of that planning before they even get ready to quit. So it's more than just the nicotine cravings. It's somewhat, if it was that easy, people would be able to quit very easily. So it's behaviors, it's the psychology, it's what we use that drug for to help us with that actually is the having to undo it. That's why the recidivism rate is so high. That's why if you look at studies that have looked at some type of product for smoking cessation, if it's 12 weeks, yeah, you can get almost everyone to quit for 12 weeks. Look at the 6-month data, or look at the 1-year data. Those are usually more telling. So a lot of people, I would say 1 in 10 rarely make it to, 1 in 10 make it to a year. It usually takes about 6 months for a behavior to be unlearned and a new behavior to take its place. So think about when you think about something you have decided to change in your behavior. You don't have to tell me, just think about it. So it could be something like dieting or changing your exercise, or something that's annoying that you want to quit doing, or you want to institute a new behavior. People can do it for a very short period of time, but it takes about 6 months of doing that behavior before it becomes ingrained and you don't have to think about it. It's the same with smoking. It's the same with the behaviors that surround that. So that's why that 6-month mark is really important. When I talk about ways that you would interact with people as a provider, the follow-up is really important. The 3 critical times when people usually fall off their efforts is the 1 week, the 1 month, and the 6 month. So in our clinic, we always plan those follow-ups in advance so that we could either talk to them on the phone, or we had them in the clinic talking to them about what had happened and how they're doing. A lot of it's problem solving. What are you going to do when? Planning ahead, having a plan, and executing it. Those are all key. Okay. So looking on, let's say, page 4, the one, yes, you're on that, the epidemiology, this is the CDC. You'll see that one of the big reasons as providers we would like them to not smoke is because of the impact on health. And there are the annual deaths from smoking in the United States. Heart disease is huge, huge. Next to being sedentary, the most modifiable risk factor there is for cardiovascular disease to decrease risk is cigarette smoking. It's almost twice the number of some of the others, so it's really important to try to get them to quit. Chronic obstructive lung disease, so mostly COPD. COPD would be a rare disease if we did not have smokers. But it's very common. It's one of the top 5 causes of death in the United States. Lung cancer would also go along with that. And you see the other cancers. Cigarette smoking is linked to about 5 different cancers that it is listed as one of the predominant causes. So let's look under that first picture. So the number of people who smoke has fallen. So in the early 60s, the Surgeon General came out and said, it's bad for your health. And from that time, we've had a decline, especially in men. Women for a while rose in number, but we're back to about 15 out of every adults 18 years and older smoke. So that's about 36, 37 million people in the United States. And 16 million live with smoking-related diseases. Doesn't mean they were smokers, could be secondhand smoke as well. Look at the number of kids. So about 5 million middle school and high school use at least one tobacco product, including e-cigarettes, which I'm going to talk about later. 90% of people who are current cigarette smokers started before the age of 18. That is why it's so important to get kids. And the tobacco companies know that, and so their ability to hook is very subtle. It used to be more blatant. You all probably, or you may remember the camel. So, what was his name? Joe. This was a real, I've taught this subject for a long time, but it was a real eye-opener to me is that my son went to a daycare very near the OU campus where I worked. And we were going down I-35 and he was about 4 years old and he said, "There's Joe." And I said, "What?" I looked up, I had driven by this billboard every day, never paid attention to it, but he knew it and he already recognized it at 4. He could tell me the name, and so advertisers really know how to get at kids.
When I was over in Europe, we had bubblegum cigarettes. I remember doing those, they were the coolest thing ever.
Well, you said little candy sticks. The what?
I remember like smash like a roll of Smarties, and you'd like smoke them. Do you remember that?
Really?
Like, on the smoke? I mean, it just like it looked like you were like creating a puff of smoke, and I remember that was like so cool in elementary
I
school.
thought that was Pixie sticks that people did that with.
No, you did Smarties.
No, we snorted them.
You lit 60
Why was it ever considered a good idea to light up cigars after a baby's been born?
Oh, I don't know.
Celebratory.
Yeah, it's a celebration. It's like when Alabama beats Tennessee. It's the big, they all get cigars and the winner smokes and takes pictures of it. Okay. So let's see. Look on the very bottom right-hand corner. So tobacco use in the past 30 days among high school students. Smokeless, 6%. Big problem in this state. Hookahs, 7.2%. Cigars, 8.6%. Cigarettes, close to 10%. E-cigarettes, 16%. They are the most growing category, age category in terms of e-cigarettes.
Are e-cigarettes and vaping the same?
Yes, yes, yes. So 7,500 adults die from smoking-related illnesses every year. That's in Oklahoma. 22% of our population smokes. So we're either at the top or the bottom of everything. We are. It's sad. $1.6 billion spent on healthcare costs in Oklahoma in a decade ago. That was the most recent. So about 25% of non-smokers are exposed to secondhand smoke where they live, work, and play. You all may not remember this, but it was about, when I was on the Health Science Center campus, it was either 90 or 91, the VA decided to go smokeless. It was scandalous. The smokers were up in arms because their rights were being treaded on. In the College of Pharmacy, we had people who smoked. I had to share an office with a graduate student who smoked. So it was everywhere. So that was a big step. And pretty soon after that, then the Health Science Center went the same way. So having smokeless restaurants, buildings, very unusual. Only in the last, well, we're coming up on almost 30 years. So in your lifetime, you may not have seen it, but it was pretty prevalent before that. So secondhand smoke, heart disease, stroke, lung cancer, all raises the risk of non-smoking adults. Children, it is thought to contribute to SIDS, acute respiratory infection, ear infections, more frequent and severe asthma attacks. We know that in children who are around adult smokers that their lungs do not develop as well and not to the same extent as it would if they had not been around smokers. So children breathe in smoke at home, daycares, in the cars. That's one of the worst. That was one of the hardest things conversations I had to have with adults is don't smoke in the car. And a lot of it, the parents may not smoke, but the people who pick their kids up or their grandparents smoke. So you think about it, they close, especially in the winter, you close up the windows. So they've taken off those commercials. They used to have the kids that smoked, they'd say, "I'm up to 2 packs a day." Did you ever see those? Brilliant. Brilliant. commercials, and very true. So the smoking rate has declined 21 to 15%, so that's a good thing. Men still are more likely to smoke than women. Younger people more likely to smoke than those over 65. Some of it's due to attrition. They die before they get to the 65. Or people over the age of 65, closer you get to the end, the more healthy, sometimes the more healthy things you develop. Highest among some ethnic groups like American Indians, Alaska Natives, lowest among Asians. Except when you go to China.
I was going to say,
And
I thought
everybody smokes in China. That's in the United States. It is usually the more education people have, the less they smoke. Usually the more poverty they exist in, the higher the smoking rate. Highest in the Midwest, lowest on the coast, on the West Coast. Smoking damages nearly every organ in the body. Smokers miss more work. They visit the doctor more often. They're hospitalized more often. They die 10 to 12 years sooner than non-smokers. A lot of insurances are moving towards higher premiums for smokers. They are doing that on this campus. So if you're a smoker or you have a dependent that's a smoker, you pay a higher premium. $170 billion on medical care to treat smoking-related disease in the adults. Okay, so if you weren't convinced, maybe that will help. So general approach. About 20 years ago, there was a study done that asked people the influence that their provider had on their smoking status. And most people, over half the people reported that their doctor never mentioned smoking, ever. This was looking at physician providers. And those that had quit said they had done it at the advice of their doctor. So you do play a role. I do find a lot of providers just quit asking, either because some patients get really irritated with you to continuing to bring it up. Others just give up. It's like, okay, it's your choice. They get tired. It's like diet. They get tired of it and they stop asking. So your asking is really important. So there's an approach called the 5 A's, and they're listed here. So so the first is ask. Ask about tobacco smoking. Now that we have electronic medical records, it's usually one of those fields that they won't let you not answer. As a provider, you'll have to fill it in one way or the other. The other is advise people to quit. Now, it doesn't mean they will, but they have heard it from you as a provider. It does make a difference. It carries weight. Assess their willingness to quit. So I would always ask people, have you thought about quitting? Are you making any plans to quit? The more I saw patients, the more I knew them, the more honest they were. No, not going to do that right now. Can't do that right now. But I always kept asking about if they were thinking about it. Assist in quit attempts. So people are at different levels or at different points in terms of considering it. So some people don't even think about it. The younger they are, they may not worry about the consequences. As they get older, they may start contemplating. Here was the big thing I found at the VA is that when they had somebody close to them, a friend or a family member, have a heart attack or die, they really started thinking about it and would make more serious plans to quit. And then some people are in the planning stage. Yes, I am going to quit, but I need to get through this stage in my life, or I need to get past this. Or usually the first of the year is a big one. Yep, I'm going to quit after Christmas. So the first of the year, January, a common time people will set a quit date. So in assisting quit attempts, 2 things we know that work. One is behavioral therapy. Behavior modification usually goes a long way. The best people who have the most success in quitting are those who have some type of behavior modification formal, and use a pharmacologic agent. That is better than either alone. So using a nicotine replacement product or some type of counseling. And now there's all types of counseling on the market that people can get access to. And so under that, under assist, so advising people why it's important to quit. You would think everybody would know, but not everybody does. Identify the risks that they have associated with smoking. The rewards of those who have quit. If you look on the back page, let's see, it's 20 for me, it's probably 19 or so for you. You'll see a get on the path to a healthier you. I don't know if this poster is available anymore, but there are probably some like it posted in your office space because it outlines all the good things that happen as you quit smoking. So if you look at the top, you found it?
Yes.
Okay, so if you quit right now, within 20 minutes, your heart rate and your blood pressure drop. In 12 hours, your carbon monoxide level in your blood drops to normal. Within 3 months, your circulation and your lung function improve. In 9 months, you will cough less, breathe better. In 1 year, your coronary artery disease cuts in half. It never goes to normal, but it gets pretty close to non-smokers' risk. After 5 years, your risk of mouth, throat, esophagus, and bladder, those are 4 of the big ones. Your risk of cervical cancer and stroke return to normal after 5 years. 10 years, you are half as likely to die from lung cancer. Your risk of larynx, pancreatic cancer decreases. In 15 years, your risk of coronary artery disease is the same as a non-smoker. So I would even tell people at the end, it's always helpful. It always helps. You all are all on still the upswing of your pulmonary capacity, and lung function is still on the rise. You haven't hit, unless you're over 35, you haven't hit the top yet. But once you hit about 35, it starts to decline at the rate of about 10 mils a year. If you're a smoker, it's 5 times that. The rate of decline speeds up. So at any point that you can get people, even with COPD, to quit, the better off they will be. The problem is that a lot of the damage can be irreversible once you get to a certain point. So the sooner the better. Always asking them roadblocks. Always ask them, what's the barrier? What is keeping you from stopping? Sometimes it is, if the spouse smokes, it's really hard. It's really hard for one person to smoke in a relation, or to stop smoking in a relationship. Repeat motivation every time they come to the clinic. Arrange a follow-up. There's that 1 week, 1 month, 6 months. The other thing to tell people, would tell folks all the time, usually the more times you have attempted to quit smoking, the more successful you would be. The first time people to attempt quitting usually are the least successful, except those that go cold turkey. I look at people who can do it cold turkey, usually are not as addicted. They usually can do it, but very few people can do it successfully and stay a non-smoker. So I always encourage people, because they will learn from it. They will know what made me go back. People can quit and in 5 years later pick it back up. So there's always something that will set them back to that path again. So the more attempt quits, the more successful people are. It's one of the few things in life where the more times you fail, the better your chance. Okay, questions about that? Yes?
Do you think people that quit cold turkey have more of a stable psychological state?
No, I think they're not as addicted.
Just
I do. I think it mostly goes to addiction. Even strength of will is hard to overcome in an addiction, but I just don't think they're that their body addiction to that nicotine is not as strong as someone else.
It's possible though. I mean, my grandfather had been smoking since World War II, and then when he had my uncle, he was in the hospital, my uncle was super sick. And I guess he started like throwing up, and the nurse was like, your cigarette smoke is making your son sick. And it just like hurt his heart, because his like son, who was already, you know, really bad off, he was making him worse. So he put out a cigarette and never touched on it again. It was just a sheer will thing.
And lots of stories like that where it affected somebody else.
Does most of this information stand also for chewing tobacco? Like quitting chewing?
I don't know. That I don't know. Possibly. But it's different. There's different toxins in there. So when you smoke a cigarette, you are smoking so much more. If you look up on the page before that, just a few of the chemicals and poisons in the tobacco. So you have benzene, butane, ammonia, toluene, cadmium, hydrogen cyanide. I think there's like 1,000 chemicals. So I would say that it's very different from chewing tobacco. But does the addiction potential exist? Certainly with the nicotine it does.
Have you guys seen that commercial that was like, look at all this stuff, you have to have a PhD to even say these names?
That's true.
Dr. Latessi,
Yes.
I just have a really curious question. We were just talking about, can you only get nicotine through the actual smoking of a cigarette?
No.
Like if you're like, oh, I'm gonna quit, but I'm gonna go to the casino every day and just.
Then you got secondhand smoke.
So,
Yeah.
but like you won't get your fix though, is what I'm saying. I'm dumb, but I'm just curious.
I don't know that. The problems that come from secondhand smoke are a lot of due to the other carcinogens in the smoke. So I don't know that. I would say probably not, because the nicotine is metabolized.
Okay.
And I don't think exhalation is one of the routes of elimination. I don't think.
Okay.
Another curiosity question, for secondhand smoke, I know like my dad smokes and we have like babies in the house, so he smokes outside and we tell him to like leave it out there and everything like that. When he comes back in and it's on his breath, is that still considered secondhand smoke?
No, I
or
don't
does it
think
have to
so.
do with like specifically the smoke?
It has to do more specifically with the smoke.
Okay, so the fact that it's like on his clothes and things like that, that doesn't really affect
I don't think so. The one thing I have found where sometimes where smokers will isolate themselves in a house is you have to look at the ventilation system. And if they smoke in one room, it doesn't matter. It depending on how the room is, or the house is ventilated, it still affects everybody in the house. So if he truly always just smokes outside, I don't think there's any risk. Okay, behavioral modification therapy, offered to everyone who wants to quit. It is improved chances if they will use it with either nicotine replacement product or one of the other agents like Chantix or Zyban. The counseling, so in terms of lots of different counseling methods have been evaluated. Here's what seems to be the best. So the dose-response relationship between intensity of counseling and success is usually more sessions are better than 1 or 2. So 4 to 7 seems to be associated more with cessation rates. And that may be that people are more interested in smoking or likely to go to more. So that may go to actually interest or desire. Longer sessions, greater than 10 minutes, usually associated with greater success. The format also tends to have an effect. So pamphlets, flyers don't tend to have as much effect. More one-on-one, whether it be telephone or in a group, seems to be better. You're aware that we have a quit line in Oklahoma, 800-QUIT-NOW. We got that as part of the tobacco settlement that came about 10 years or so ago. So they will counsel, they'll do an intake, they'll get a history, they will provide counseling on the phone, and they can provide gum and, I think patches and, gum and patches, I think. to the people who call in. So it's really a very good system for people who have limited funds or can't afford to go to counseling. This is a good program. When you get to an area wherever you're settling in, look to see where those programs exist. The ones that are going to be the best are those that are going to address problem-solving skills and stress management. And then relapse prevention. Those three things are key. You have to teach people a different way to handle their behaviors. And problem-solving is huge. And then it will be stressful to them when they when they go through the process. So how is that supported within in the system? So the pharmacologic, the nicotine replacement will only handle the withdrawal symptoms. So it's not going to handle all those other things. That's why by itself it's usually not as successful as we'd like to. Support is a big thing. Whenever we go through and teach and talk and go through a smoking cessation program, at some point we would ask them, have you told anybody? A lot of people won't. And so to me that's always a big sign. Because it usually means there's not the support in the house, or no one believes them anymore, or they are worried that if I do tell them, I really will have to go through it. So at some point, usually towards the end, when they've really made a commitment, we ask them to tell people and ask for their support. You know, one of the other things you don't realize, and this was an eye-opener for me, is that people would tell me, they would come back after they quit, they go, I've lost my circle of friends, because when I used to go for smoke breaks, those were all my buddies. And so now I don't see those people anymore. So I didn't even think about that. Some people went back to smoking because of that. Some would go and vape with their friends while they smoked, they vaped. Some places will let you use e-cigarettes indoors and others will not. So that it shows up in all different areas. Pharmacotherapy, offer it to everyone who's going to quit unless there's a contraindication. There aren't that many contraindications unless you have an unstable cardiovascular disease. Is probably one of the bigger ones. So the drugs will help them with long-term abstinence rates. It usually will force is probably a bad word to use, but you have to set a quit date for some of them. With Chantix and Zyban, you start the drugs before the quit date. So you have to have that kind of commitment. Now the nicotine replacement products, the day you quit, you can start picking those back up. But trying to smoke and use nicotine replacement products is not a good idea. You get too much nicotine, you put them at increased risk for often cardiovascular side effects. Medication is mostly based on patient preference. We're going to go through each of those. And there's lots of different forms. Remember what I told you about forms? The more forms there are for a drug, it's usually the market is demanding or they're trying to hit every niche. And we'll see that with the nicotine replacement products. Okay, any questions or comments to this point? Yes?
Have you ever heard of an insurance company covering that therapy, like the behavioral modification? Or is that something else?
I would not, a lot of them will have mental health. I don't know if they put it up under that kind of. Usually the better ones will pay for like a year's worth. So that may fall under there. I don't know. A lot of companies will limit the amount of smoking cessation products they will provide because they know the rate, the recidivism rate is so high. So a lot of them will cover like 3 months worth. Like Medicaid, when I was at Family Medicine, they would only cover 3 months. And that was in a certain time frame. I can't remember now, maybe 3 months a year. I don't remember. Yeah.
Who specifically would you refer them to for the behavioral modification therapy?
You would have to find who in the city does it. If you're in a big complex, like on the family, like the VA has them, they provide them. On the OU campus, we had groups on campus that would do that. As a provider, I don't know about PA status, but they will reimburse physicians for smoking cessation counseling. So does that work? It probably depends on the provider and how good they are, and if they're trained and if they know what to do. The I Quit is probably a good place to start if you've got people who are very willing. It works well with a lot of people who don't have a lot of money or they're working and can't get away. Lots of different groups will provide it in some form. Yes. All right. So let's look at the pharmacologic therapy. Start with nicotine replacement. So here, this is to provide the person with a source of nicotine that isn't in the cigarette. And it's to relieve the symptoms and while the person works on the behaviors that are surrounding that they're smoking. I think that is a big thing for you all to point out. You know, yes, I can give you something to help you with the withdrawal, but you are going to, the big part of the problem is the behaviors that you have associated with that, so that they are aware. In terms of the safety of nicotine replacement products, they're pretty safe. They don't lead to nicotine dependence, except in one of the nasal spray is a very high concentration, and people do tend to get more dependent on it. Some people stay on the gum a long time. The recommendation is like up to 6 months, but a lot of people will stay with the lozenges or the gum for long periods of time. They don't cause cancer. They can be used in patients with stable cardiovascular disease. So unstable would be like after an MI, or if they're having unstable angina, or they're having arrhythmias that are not well controlled, that are causing then cardiovascular side effects. They do produce the same adverse reactions that nicotine would. In terms of efficacy, they've been shown to be effective. They increase the quit rate by about 2-fold over doing nothing. There's very few head-to-head studies. So head-to-head means they compare gum to the patch. That would be a head-to-head. So you've got two products that are used for the same thing, and they compare them against each other. You don't see those very often anymore. Companies don't like to do that because there's too much risk and they're expensive. So those used to be the gold standard way of doing it, but we don't see those very much as well. So it doesn't appear, there's a few studies that have looked at those, but for the most part it appears that regardless of the form that people choose, nicotine replacement is effective. Some evidence that combining, and I'll talk about this, is that we combine a long-term nicotine replacement. We used to not do this, but combining a patch with a short-acting like a gum or a lozenge is now considered an approach for some patients. So the products in the United States, some of them are over the counter, like the gum, the lozenge, you can get those over the counter. Some of them require a prescription. Nasal spray and the inhaler both require a prescription. The long-acting, the only one we have that's long-acting in the United States is the patch, and that one's over the counter as well. There may be one that is still prescription, but people can get a patch over the counter. The short-acting agents are the lozenge, the gum, the nasal spray, and the oral inhaler. The big difference between nicotine replacement products and smoking is the speed, the onset of effect, and the peak levels that you get. So, the nicotine replacement products do not get nicotine into the brain as fast as smoking does. When people smoke, that nicotine gets into the brain very quickly. With the products outside of the nasal spray, they are slower, and the peak amount is much lower. So they'll tell you it's not the same, and it's not, they're right. So lower nicotine levels, longer onset. I think telling them that is helpful. At least they know ahead of time. Nicotine replacement can be used in combination with like Zyban or Chantix. So that's good. You got two different pharmacologic effects, and that is effective. Mechanism of action, there is very similar to what we talked about on the first page, is they stimulate those nicotine receptors. Contraindications are low unless they've had an allergic reaction or they have an unstable cardiovascular event like post-MI, life-threatening arrhythmia, severe or worsening angina. Side effects will go through each one of those because they're a little bit different for the different dosage forms. Okay, we're going to go through the gum and probably the lozenge during the quick break. The gum's been on the market the longest. It was the first one to come out. It is nicotine that is in a resin, in a matrix. So in order for it to be released, it has to be mechanically manipulated like chewing. And it is designed to come out over a longer period of time, over about 30 minutes. So there's the gum. These are the two. Nicorette is the brand name. It is available generic. Walgreens has a brand. Walmart has a brand. CVS has a brand. I love it because they put it right next to the tobacco. Up front. Sometimes they're in the back as well. So here you'll see, so you got that polyacrylic resin. It's absorbed through the oral mucosa instead of through the lungs. So a little bit different. The peak levels are in about 20 minutes. So that's a long time. So one of the things, and this is later a little bit down in the handout, it is better when you start these products, either the lozenge or the gum, is that they be scheduled. So we would put them on like every 2 hours. You're going to chew a piece of gum or you're going to take a lozenge. We found people did better. In the past, it was whenever you feel the urge to smoke, chew a piece of gum. Well, that didn't work because they were already behind the 8 ball in terms of getting instead of forestalling the symptoms. Contraindications with this requires a lot of chewing and more vigorous chewing. So people who have TMJ, temporal mandibular joint disorder, usually this will make it worse. The other would be, because they're going to chew up to 20 times, 20 pieces of gum or lozenge, the gum, a day. Have you ever chewed a lot of gum? And your jaws ache? Okay, that's what these people do multiple times a day. The other would be dental appliances, so like dentures or bridges, partials, it'll stick. It's very sticky. So a lot of times it doesn't work for them. If they have poor dentition, if they don't have enough teeth, then they can't chew the gum. So a lozenge would be better for them. Now, they come in 2 strengths, 2 milligram, 4 milligram. Be sure you know this, so circle it. Taylor Cassie says to know this. Is that in terms of what dose you use goes to how many cigarettes a day do you smoke, and how soon do you need a cigarette when you get up. If your addiction is higher if you have to have a smoke before you get out of bed. So within the first 30 minutes of waking up, if you need a cigarette, that would be considered, you would need a higher dose. If you get up, tool around, after 30 minutes you smoke, then you could probably go with the 2 milligram. So cigarettes per day, less than 25. How many cigarettes are in a pack? 20. Right. So a little bit more than a pack a day. 2 milligram strength, more than 25 or more, 4 milligram strength. Putting them on a schedule. Every 1 to 2 hours, we want them to chew a piece for the first 6 weeks, then decreasing over to a 12-week. A lot of people go way beyond that, but that's the recommended dosing. I would say it's most important to get them on that schedule early on, then they can self-taper. That won't be a problem. This is up to 24 pieces a day. I think the lozenge is 20. Proper chewing technique is really important. It is a chew and park approach. If you look on the next page, there's a picture. Any of you ever tried them? You might suggest to people is to try the flavor. They can make an orange flavor. I think there's also a mint flavor. The original is not as palatable, so you might have them try like the orange to start. So what we have them do is chew it until a peppery taste comes in their mouth, and then we say park it. So when we say park it, it's just put it in the buccal space, so between their cheek and their gum. And then as that subsides, take it out, chew it again. And that takes over about a 30-minute period. If they chew it too fast, they'll get side effects. They'll release too much nicotine, it'll make them sick to their stomach, gives them hiccups, might cough. They will get a sense, but chewing it and parking it is really important to get the full amount or the full effect of the nicotine that's in there. A couple of things to remember: eating and drinking beforehand. Don't drink or eat while you've got the gum in your mouth. So you can see it becomes kind of if you're doing this every 2 hours, you're probably not going to be drinking much through the day. Water is fine. Acidic beverages are a problem. Coffee, sodas, acidic will tend to interrupt the release of that nicotine from the gum. The other, let's see, chewing properly. Side effects usually due to chewing too vigorously. So sore mouth, sore gum, sore jaw, upset stomach. You ever seen a kid who's eaten a cigarette? It used to be a bad problem. People would, throw their kids, dig through the trash, get a cigarette, eat it. Yeah, it gets them very sick. They can get nicotine poisoning. So it's very hard on the stomach. So I think also telling them that this pharmacist should tell them that they can go in and buy it without ever talking to anybody, is to let them know it takes a little bit of practice to get the technique down. So the dyspepsia, hiccups, common. Salivation is increased salivation, mouth ulcers or irritation. So very effective, but need a little bit of practice. In terms of cost, the generic and the brand are about the same, but with the generic you get more pieces. So this is for a brand, it's about 100 pieces. For generic, it's closer to 200 pieces. So it's cheaper to go the generic route.
Dr. Tassie?
Yeah.
With them having the gum and parking it and all of that, does that increase their mouth cancer risk?
No.
No?
No.
Okay.
Good thought, but no. Let's see. Let me cover the lozenge because it's very similar to the gum, and then we'll take a break. So the thing with the lozenge is that you get around the chewing part. So mostly it is letting they just have to put it in their mouth, not chew it. Don't chew a lozenge. They make them in the lozenge now in the little mini lozenges, which look like little Tic Tacs. The same goes for the food and the acidic beverages stuff. So that is still common. So for people who have TMJ, who have dentures or poor dentition, this is a reasonable alternative or a first choice, either one. Again, we would say schedule it. The dosing is the same based on cigarettes, cravings. But I think the amount is 20 lozenges a day. Did I put that in there?
Yeah.
Yeah. 20. If you look on the next page under directions, there are some limitations in terms of amount. So they do recommend not more than 5 in 6 hours or 20 per day. They'll know because it'll make them sick. So just advising them in terms of learning about it. Not using more than one at a time. Don't chew it. And the cost is very similar to what you see with the gum.
Is it in the buccal space or sublingual?
No, not sublingual, buccal. And absorption of the buccal space is very similar to sublingual. It's very fast, very rapid. It's you got a lot of vasculature in there for it to be absorbed. Questions? Okay, exciting stuff. Okay, we'll come back and we'll pick it up with the spray. We'll come back about 5 after.
I'm just